Hi, I'm Clara Keegan. You're about to hear me talk for about 30 or 40 minutes about different contraceptive methods. As I was putting this video together, I realized that there was something definitely lacking. This is not a presentation about transgender care or about taking a sexual history, but I definitely want to preface my presentation with a few words about those topics. Contraception has traditionally been defined around the needs of heterosexual, cisgendered couples, but many people who don't fit in that box are at risk of unplanned pregnancy. When I was in medical school in the late 90s, the revolutionary way to take a sexual history that I was taught was to ask, are your partners men, women, or both? But recently, I have learned that a much better question to ask is, what types of people do you have sex with? And we'll get the same information that we're looking for. If that question confuses people, the information we get will still be interesting and might spark a conversation. When starting to frame a conversation around contraception, it's useful to know what reproductive organs your patient that you're speaking with has. For someone who has a vagina and a uterus and makes eggs, I might ask, do any of your partners make sperm? And that would help me know if that person was in need of contraception if they did not want to become pregnant in the near future. Please remember that testosterone as gender-affirming therapy for trans men and non-binary people is not adequate hormonal contraception. So someone on testosterone who makes eggs should not rely on that to prevent pregnancy and may need an additional method. I hope that even if you know a lot of what I'm going to talk about in this presentation, there is something that you find useful. My email is at the end in case you have any questions. May the 4th be with you. Hi, I'm Clara Keegan, and I'm a family physician here at the University of Vermont. During the first week of the Family Medicine clerkship, one of our activity sessions is focused on women's health, where medical students have an opportunity to explore some of the different contraceptive methods available and ask questions about them. I'm going to try to recreate some of that for you today, but I'm sure I won't be able to answer every question. So let me know if you think of anything else that I need to include. In this session, I'm going to go through a wide variety of different contraceptive methods. Some are fully prescribed and administered by a physician, and some are completely over-the-counter and don't require any physician involvement at all. I'm going to try to talk about how they're used, how they work. The slides will tell you how effective they are in terms of how many people would become pregnant in a year of use, and I'll give you some tips or tricks along the way. In this slide, I've divided the contraceptive methods I'm going to discuss into hormonal methods on the left and non-hormonal methods on the right. The hormonal methods are further divided into those that contain estrogen and those that do not, because there are many clinical situations where we need to avoid using estrogen. The methods at the top, specifically the implant and the IUDs, are what we call long-acting reversible contraception, and these are considered the most effective methods because they really have no room for user error at all. They're placed by a provider, and then they do their work. They're pretty much impossible to mess up because they just sit there working until they are removed and possibly replaced. Combined oral contraceptives were released in the middle of the 20th century. The original pill contained 50 micrograms of ethinyl estradiol, and this definitely increased the risk of blood clots. So modern pills typically have no more than 35 micrograms of ethinyl estradiol as the estrogen component. It's actually the progesterone that does the work of preventing ovulation, but the estrogen helps to regulate the menstrual cycle. So the pill has a lot of benefits that are related to the menstrual regulation besides contraception. The pill can really help with acne, and it also reduces the lifetime risk of endometrial or ovarian cancer. So the longer someone has taken a combined oral contraceptive, the lower her risk of those cancers, no matter how long ago she stopped taking the pill. And that's because those cancers are so greatly linked to ovulatory cycles. So by having fewer ovulatory cycles, the risks of those cancers are decreased. In addition to prevention of ovulation, when taking the contraceptive pill, the endometrium becomes thin and atrophic, so the periods typically become lighter and lighter. Also, the cervical mucus becomes thicker, so it's more difficult for sperm to reach an egg. The contraceptive pill was designed to mimic the menstrual cycle. The typical pill pack contains 3 weeks of active pills, followed by 1 week of placebo pills, during which the patient would have a menstrual period. The pills are taken first from the top left corner and then are taken one a day from left to right until the 4th week is the placebo pills. The packs have a little hole in the back so you can punch the pill right through the back of the pack. The traditional recommendation was to wait until you finished your period and then start your pill on the next Sunday following. That recommendation was to make sure that the patient was not pregnant when she started taking the pill, and then if she started the placebo week on a Sunday, she would have her period during the middle of the week, leaving the weekends bleeding free. Scientifically, however, there's no reason that it has to be done that way. People can start the pill on any day of the week, and we can figure out when it's safe to start the pill by asking the patient questions. So if we tell someone she has to wait until her next period, the patient might forget to start the pill or might never get a period if she has irregular bleeding, and she might have an unplanned pregnancy before she started the contraceptive. So I usually use the quick start method. This involves asking the patient when was the first day of her last period and when did she last have unprotected intercourse. If it has been fewer than 14 days since the beginning of her last menstrual period, then we can rely on a pregnancy test that's negative to tell us that the patient is not pregnant. If it has been more than 14 days since the first day of the last menstrual period, then the patient may be at risk of pregnancy if she's had unprotected intercourse. We can still start the pill, letting the patient know that we would like her to do a pregnancy test in about 2 to 3 weeks to make sure she's not pregnant. But if she did become pregnant, starting the pill during an early pregnancy would have no adverse effects on that pregnancy should she continue it. Many women will not be pregnant and thus will have not delayed starting the pill and can get started on their method right away. The packs typically come with a sheet of stickers that allows you to change the start date in the week. So if you start your pill pack on a Tuesday, you would put a sticker across the week that would instead label this column the Tuesday column, and this would be Wednesday, Thursday, Friday. There are many different formulations of combined oral contraceptives available. Like I said, they all contain ethinyl estradiol as the estrogen. There are 4 generations of progesterone. The 4th generation is a progesterone called drospirenone and others that are similar to it, which is in brand name Yaz or Yasmin. And these are meant to have no androgenic effects at all. So theoretically, they are helpful for women with PCOS symptoms like hirsutism or acne. All the combined pills will help with acne to some degree or another, however. I can't keep in my brain which progesterone is in which generation and what effects they might have. So I rely on a reference book called Managing Contraceptive Pill Patients by Richard Dickey, which helps me through 2 really great charts. One chart lists all the different formulations of contraceptive pills that are available as of that edition and tells you how much activity they have in terms of progesterone or estrogen or androgen. And then another chart goes through different side effects that people might have and tells you whether those side effects are due to too much estrogen activity or too much progesterone activity or too much androgen activity, etc. So you can figure out which side effects someone is having and then decide how you want to change the balance and choose a pill that is different in balance for that. I often find that people have side effects that are related to too much estrogen and too little progesterone. So I actually often will use this exact pill here, which was originally branded as low estrin, but is now available as microgestin or Junel or a variety of different names, which has 30 micrograms of estrogen and 1.5 milligrams of norethindrone as the progesterone. And it seems to have a pretty good balance. So this is usually my starting pill. Because it can be difficult to remember to take a pill daily, estrogen and progesterone are available in 2 other administration methods, the patch and the ring. The patch delivers 20 micrograms of estrogen and 150 micrograms of norelgestromin as the progesterone per 24 hours. When the patient picks up her box of patches, it has 3 patches in it. There is a sticker sheet which allows the patient to mark the calendar. Again, to mimic the menstrual cycle, this is labeled to use 1 patch per week for 3 weeks in a row, and then have 1 week without a patch during which the patient would have a period. The patch is about this big, And I recommend that people put it on immediately after a shower. Dry off really well, don't put on lotion. Hold the patch in place with the hand for about 30 seconds because warming it up will help the adhesive stick better. Then apply a little bit of powder to help catch any adhesive that might be on the edge of the patch, to help avoid that adhesive catching on clothes and pulling the patch off. If the patient realizes that the patch fell off, she can immediately replace it with a new patch. It's a little hard to do continuous use with the patch because insurance typically only wants to pay for one box of 3 patches a month, but someone could use a 4th active patch the 4th week as well to suppress the period. There is no placebo patch to use. The contraceptive ring is available under the brand name NuvaRing. It delivers 15 micrograms of ethinyl estradiol and 120 micrograms of etonogestrel as the progesterone per day. It is dispensed as a single ring at a time. It's a clear, flexible ring that's designed to go inside the vagina and sit there. The patient places the ring inside the vagina, and once it's behind the pubic bone, it will stay in place. It can be removed with a single finger that hooks underneath the ring and pulls it out easily. It can remain in place during intercourse, and usually a partner would not be aware of it at all. If a patient prefers, she can remove it during intercourse. I usually just say leave it on the side of the sink, and then as long as she rinses it off and puts it back in within 4 hours after intercourse, her protection will not be interrupted. The ring is designed again to mimic the pattern of the patch and the pill, with 3 weeks of continuous use of a single ring in the vagina, and then the ring is removed for 1 week, during which the period would occur. Studies have demonstrated that hormone levels in women using the ring remain steady for 5 weeks with a single ring. So this gives a woman a lot of control over her menstrual cycle. There's no reason that it has to be placed on a specific day of the week and changed on that same day of the week. If it's easier for someone to remember, she can put it in on the 1st of the month and change it on the 1st of the month, and then have no menstrual period at all. If she wants to have a period, she could place it on the 1st of the month and remove it on the 24th of each month, and that would stimulate a menstrual period as well. So there's a lot of control that the patient has by using a ring. Since insurance pays for 1 ring a month, there's no arguing with insurance companies about coverage because the single ring for the month will be enough to suppress the period. The pill, patch, and ring are very similar. The benefit of the patch and the ring is the administration method, and if that works for somebody, that's really great, but we can't alter the amount of hormone. So if we need to change based on side effects, the pill gives us a lot more flexibility in terms of which formulation we use. The other issue with the pill, patch, and ring is that they contain estrogen, and estrogen has higher risks than the progesterones. Specifically, it increases the risks of blood clots. Women have a higher risk of blood clots when they're using an estrogen-containing method, and that risk is higher depending on how high the estrogen level is. The good news is that young, healthy women have a very, very low baseline risk of blood clots. So even though that risk is increased by the estrogen, it still remains a low risk. Once somebody has a DVT or a pulmonary embolism, she shouldn't use estrogen again, however, for her lifetime. We also don't recommend estrogen-containing contraceptives for people at a higher risk of stroke or heart disease. That includes people who have migraines with aura. This is being studied, and we may have good evidence that we don't have to give that, 100% you have migraine with aura, you can't use estrogen recommendation that we've been giving for years. There are definitely people whose migraines are worse when they're on estrogen, so they really should avoid estrogen for their symptoms, regardless of whether the stroke risk is increased or not. Another situation where we want to avoid estrogen is when people have an increased risk of blood clot. So that includes people who are smokers over 35, or if someone needs to be immobilized for a long time after surgery. And in addition, the weeks after delivering a baby are a higher risk of coagulability. So we don't want to use estrogen in the first 4 to 6 weeks after delivering for women who are not breastfeeding. And if someone is breastfeeding, we extend that even longer. There's also a possibility that estrogen would reduce the production of breast milk. So we usually recommend progesterone-only methods while breastfeeding, especially in the first 6 months when babies aren't eating additional foods yet. Estrogen methods aren't recommended in active liver disease because the liver metabolizes the hormones. So it can be affected if someone has severe cirrhosis or active viral hepatitis. When people pick up their pill, patch, or ring from the pharmacy, there's usually a sticker on it cautioning that antibiotics can reduce the efficacy of the pill. Scientifically, the only antibiotic that reduces pill efficacy is rifampin. People can take doxycycline, Bactrim, amoxicillin, most of the antibiotics that we prescribe most commonly without any effect on the pill. However, there have been effective lawsuits claiming that a pregnancy that was undesired is the pharmacist's fault for not warning the patient about the reduced efficacy. So the pharmacists will continue to place that label on the package. But I feel quite confident when I'm giving antibiotics telling people this will not affect how well your pill works. If you're worried, go ahead and use condoms as backup, but scientifically it should not affect your pill at all.